What is the best renal replacement therapy modality in the ICU? These are my conflicts of interest. This is the outline I'm going to try to follow. So during two debates, intermittent hemodialysis versus CRT, and then we're going to tackle the other one, diffusion versus convection versus the combination of both. Just as an introduction, I would like to please tell your fellows, tell your team, your staff, that we should use the correct abbreviations when we are at the bedside. Because sometimes, you know, you're around in the ICU and you hear, yeah, the patient is under CVH, and actually this is continuous hemodialysis. So, you know, CVH is for continuous hemofiltration, CVHD for continuous hemodialysis, and CVHDF is for continuous venovenous hemodiafiltration. So CRT in 2023 does not necessarily mean CVVH. The second point I would like to stress at the introduction is in the past, 20 years ago, 25 years ago, hemodialysis was intermittent, it was diffusion, and the target was the small solutes. And for hemofiltration, it was continuous, it was convection, and the target was middle molecular solutes. But today, in 2023, that's too simplistic in 2023, and in 2023, hemodialysis, you know, you have intermittent hemodialysis and you have continuous hemodialysis. Of course, this is diffusion, but also because of these new membranes, you have internal convection and backfiltration, and you have to take into account these mechanisms. So you can remove small solutes plus or minus middle molecules when you run a hemodialysis session. For hemofiltration, it's still continuous convection, and you can target small and middle molecules as well. So let's start with this debate, intermittent hemodialysis versus CRT. That's a 25-year controversy, right? So, of course, you have advantages for both modalities. If you run an intermittent hemodialysis session, you can avoid the risk associated with continuous anticoagulation. It's easily deployed at the bedside, yes, we have to admit this, but I have added some parentheses also because we have to be honest, and now in 2023, this is also easy to implement CRT at the bedside. Intermittent hemodialysis, it allows the patient to achieve great mobility. That's right. When we are in the ICU, we want the patient to move, to be mobilized, so that's very important. And it's cheaper per se. The advantages of CRT, it provides greater hemodynamic stability and continuous control of the volume status, electrolyte and acid-base status, the temperature control. It avoids solid swings and cerebral edema and provides superior uremic control. So the KDIGO guidelines tells us to use continuous and intermittent renal replacement therapy as complementary therapies in AKI patients. And they suggest to use CRT in case you have hemodynamic unstable patients or trauma brain injury or increased intracranial pressure. That's the KDIGO guideline, that's the internal recommendations. We have to admit, we have to be honest, that the level of recommendation is 2B, which means this is low level of recommendation. When you look at this debate, CRT versus intermittent hemodialysis, and you look at the outcome, the mortality, there's no difference between CRT and IHD. It's been reported in different publications. That's meta-analysis, no difference. When you look at another outcome, which is the renal recovery, this becomes more complicated. The first one who published data on that was Max Bell from Sweden. He reported a retrospective analysis comparing CRT versus intermittent hemodialysis for the renal recovery. And he concluded that when the first renal replacement therapy modality was CRT, then this was associated with better renal recovery. Same result from Canada, from Ronvald. He published exactly the same conclusion than when there is CRT versus intermittent hemodialysis. When you start with CRT, then this is associated with better renal recovery. Antoine, our chairman, published like almost 10 years ago, like a meta-analysis with this question: does it provide better renal recovery? Well, he found that if you look at the observational studies, then yes, there was a signal in favor of CRT for a better renal recovery. But when he looked at only the randomized controlled trials, then there was no signal. It was similar between CRT and intermittent hemodialysis. In France, we also looked at our data on 1 million ICU patients, and we also found a slight signal favoring CRT when it comes to renal recovery. Then came the COVID, so no publication in this topic. But then after the COVID, we got 3 recent publications. The initial top goal of this publication was to look at the timing. This is the timing studies and the dose studies. And the secondary analysis, they looked at the modality. And they found, so Stefan and Ronwald found conflicting data. Stefan did not find any difference between CRT and intermittent hemodialysis when it comes to renal recovery. But Ronwald found a benefit for a CRT as compared to intermittent hemodialysis. And for the dose study on the right side of the slide, basically it depends on what kind of statistical analysis you are running. And you can see, yes or no, there is a benefit for CRT when it comes to renal recovery. So conflicting data, we have to admit. So we are waiting for a randomized controlled trial, and Stefan, you launched the ECRAKI trial, which is a randomized controlled trial comparing intermittent hemodialysis versus CRT, and we are going to wait for these results within the next few years, we hope. So we will see in the future if the debate is still ongoing between intermittent hemodialysis or CRT, or if we should continue to use them, because this is what I do in my center. When the patient is very sick, we start with CRT, and when the patient gets better, then we switch for intermittent hemodialysis. And I bet that this is the case that you also do in most of your units. What about the other debate? Diffusion versus convection versus the combination of both. Well, we have less data on that topic, of course. There is this publication that came out in 2006 showing that a better filter patency with CVVHD as compared to CVVH, and also a slight better removal of solutes with CVVH. That's almost the only publication that we got before we, with the AKI section, led by Antoine, we got together a few years ago, and we did a working day on that topic, and we decided that we have not enough data to conclude what's best between CVVH versus CVVHD and CVVHDF. So we need additional trials, we need additional data. So we decided to launch a survey first, an international survey on that topic, and some of you, I think, replied to this survey that was launched last year, and then to launch after a clinical trial. So this survey was endorsed by the ESICM, and Céline Mona from Lyon, from my team, also took care of this survey and sent the survey across the world. The survey was available for 9 months on the ESICM website, and the primary aim was to identify factors influencing the prescription of a CRT modality over the others. We got 1,700 answers from 74 different countries from all the continents. So we were quite happy about this, and thank you very much if you replied to this survey. What information did we get? First, that the most prescribed modality in the world when it comes to CRT is CVVHDF, by far. 56% is CVVHDF, in front of CVVHD, in front of CVVH. Another interesting result, and we were expecting these results, is when you provide CVVHDF, there is a huge heterogeneity of the ratio convection-diffusion. Sometimes half convection, half diffusion, 1/3 convection, 2/3 diffusion, 2/3 convection, 1/3 diffusion. It's very variable across the different countries. Huge heterogeneity. The same from the pre-post dilution in CVVH. A lot of variety. So there is a huge heterogeneity of settings because there is a lack of studies on that specific point, right? So there's no consensus to how you should provide your CRT modality. So what do the guidelines tell us to do when it comes to CRT? The KDIGO guidelines, so there is some information about intermittent versus CRT, okay, but there's nothing on CVVHD versus CVVH versus CVHDF, not a single word. So the French guidelines, well, diffusive and convective renal replacement therapy techniques can be used equally, taking into account their availability in the unit and the experience of the team. Well, so what's new in the available literature regarding continuous modalities? I have talked to you a little bit in the introduction. We have, you have to take into account the membrane. That's very important. You have this new super high flux membrane, the middle cutoff membranes. So that's also important to take into account because sometimes you provide CVVHD. If you use a specific membrane, your solid clearance will be higher even for middle molecules than if you run CVVH with a standard membrane. So in 2023, my personal opinion, I actually like the 3 CRT modalities. I like CVVHD. Why do I like CVVHD? I like CVVHD because with CVVHD you can work with a very low blood flow rate. You don't have the issue of the filtration fraction. You can decrease your blood flow rate to up to 80 ml per minute. So that leads you can provide citrate anticoagulation to almost 100% of your patients. That's what we do in our center. We like that. We also like the fact that with CVVHD, there's no hemoconcentration within the filter, right? So you limit the formation of the protein cake. So because of that, you don't have any clogging, any clotting, so you can run the session for a long time. You can increase your filter patency. But why do I like also CVVH? I like CVVH because of this information. This hemoconcentration is not that bad because you can hemoconcentrate the middle molecules, and if you hemoconcentrate the middle molecules, you can increase the removal of the middle molecules. Okay, so I think this is very important. And why do I like CVVHDF? Because it might be the best compromise. Then you can, and this is what they found in the chronic field, right? With the CONVINCE trial, they realized that that high-dose hemodiafiltration was superior to high-flux hemodialysis. So maybe if you take this data and you put it in the acute field, you will find the same thing. So CVVHDF may be the best compromise. So that's why we are going to launch a randomized controlled trial comparing CVVHD with CVHDF. That's the whole goal of our section, AKI section of the ESICM. Dr. Franck Bidard from Lyon is the PI of this study. We plan to enroll 10 centers in France and 5 centers in Europe to answer this question. The conclusion, the model CVVH versus CVVH convection middle molecules removal versus CVVHD diffusion small molecules removal is way too simplistic. Now you have to take into account the membrane. The use of CRT as the initial modality in the ICU as compared to intermittent hemodialysis seems to be associated with better recovery after severe AKI, potentially due to a better hemodynamic stability during CRT. CVVHD allows for an extension of citrate anticoagulation indications thanks to a reduced blood flow rate. CVVH means hemoconcentration within the filter, which may lead to a better middle molecular clearances, but it also means protein cake, so please pay attention to the filtration fraction when you use CVVH. CVVHDF could be the great compromise, so let's wait for the 2 RCT that are ongoing, the ICRACE trial and the FIDIA trial. Thank you very much.
So thank you, Thomas, for this nice overview. So I have many questions in the chat. So the first question is that in some hospitals, the intermittent renal replacement therapy is used by the nephrologists, and you need them to get involved in your patients. So might this be more difficult in these hospitals to choose this treatment in all patients?
Of course, you have to adapt your practice to what you have in your hospital, where you work. I know that the care is very different over the different countries, so of course you have to adapt. But, I mean, I see more and more ICUs, and now I believe that the intensivist should take care of both therapies, CRRT and intermittent hemodialysis. I don't think it's a good idea to have people coming. They are very busy, they don't know very much the patient. So I believe that the intensivist should take care of CRT and intermittent hemodialysis.
Another question from Marcus Lowe, and it's about SLED. You haven't mentioned SLED, hybrid therapies. Is that also maybe the happy medium?
Yeah, that could be a good compromise also between like a CRT and intermittent hemodialysis. I have to admit that in France, only very very limited number of centers are using SLED. Almost nobody in France is using SLED. I have no experience with SLED, but of course it could be a compromise. In Belgium, for example, they use a lot of SLED, and Eric Roste, for example, always tells me that it's a good compromise, you have good hemodynamic stability, and the clearances are not so bad, so it could be a good compromise. Probably it's not enough studied, the SLED.
So another question from the chat is whether there might be a different strategy in patients with liver failure concerning the hemodiafiltration or hemodialysis. Is there one technique that's better in these patients for acute liver failure?
For?
Acute liver failure.
For acute liver failure, where there is no... We cannot say that one modality is better than another one for any single type of subclinical settings. Actually, in the survey, we looked at the beliefs of the responders. And it was interesting to see that in different settings, sepsis, liver failure, intoxications, a lot of people like us, like you, we believe that in some indication, in a subclinical setting, CVVH would be better than CVVHD and CVVHDF. And in another one, CVVHDF would be better. This is based on no information, no data. So I believe that we should run these studies. We should look after at the subclinical settings to see if one modality is better than another one.
Thank you very much.